Hello everyone, and welcome to today's webinar, Somewhere to Heal, an Introduction to Medical Respite Care, presented by the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration and the Bureau of Primary Health Care. This is a 90-minute presentation with the last 15 to 20 minutes reserved for Q&A. There is a chat box below the presentation slides. Please enter a question anytime throughout the presentation. If you're having any technical difficulties, please feel free to call the Council's office at 615-226-2292 and ask for Michael. Today we're going to be talking about medical respite care, and we're going to cover a lot of ground in a short amount of time. We're going to start by giving a brief overview of respite. We'll discuss different program models, components of medical respite, both clinical and social service sides, things to consider when starting a program, developing program measures and outcomes, and we're also going to talk about resources. We hope you will develop strategies for hospital partnerships, learn more about the resources available to you, including the standards for medical respite care, and we hope that you'll get a better sense of what staffing and programming structure will work best to address the needs of your community through medical respite care. My name is Julia Dobbins, and I'm a project manager here at the National Healthcare for the Homeless Council, and I am thrilled today to be joined by 5 fantastic respite providers from across the country. We have Donna Biederman in Durham, North Carolina, Shauna Brock in Baltimore, Maryland, Kim Desprez in Phoenix, Arizona, Shakoya Green in Los Angeles, California, and Dave Munson in Boston, Massachusetts. I think we've got all time zones covered by our speakers today. I'd also like to highlight that all of our speakers are members of the Council's Respite Care Providers Network, or RCPN, Steering Committee. So to get started, I just want to share what medical respite care is and what it looks like across the country. We define medical respite care as acute and post-acute care for people experiencing homelessness who are too sick to recover from illness or injury on the streets or in shelter, but are not technically sick enough to be hospitalized. Unlike respite for caregivers, medical respite or recuperative care is short-term residential care that allows individuals who are homeless the opportunity to rest, to recover, and to heal in a safe environment while also accessing medical care and other supportive wraparound services. There are 4 primary components of medical respite care: clinical care to address the acute medical need, case management to help connect clients with community resources, integration into primary care and connection with a healthcare home, finally, self-management supports. In medical respite, there is active involvement by clients in the process of their recuperation, so this is really a prime opportunity for patient education, for planning, and for practice. The National Healthcare for the Homeless Council maintains a medical respite care program directory, and as of 2016, we knew of about 80 medical respite programs across the country. The national average length of stay for a client in medical respite care is about 42 days. In terms of program capacity, here's a chart of medical respite programs by amount of beds available. As you can see, about 50% of programs have less than 20 beds. Many programs start small and work to add beds as they become more established in their communities. We aren't going to spend a lot of time talking about financing respite today. We published a policy brief on financing respite in 2017, and we also did a webinar, which is archived on our website. But I just want to give you a sense of how most respite programs are supported. So the key funders are really managed care organizations. Some folks use their health center funding, public agencies like local health departments, hospitals, which is something that Shakoya is going to talk more about, private donations, and foundations. This slide gives you a breakdown of funding. If you remember, I said as of 2016 there were about 80 programs that we know of across the country, and as you can tell here, this number adds up to way more than 80. And That's because it's extremely rare for a medical respite program to receive all of their funding from one source. It's often a combination of several funders, which gets tricky when you're thinking about your program measures and outcomes, which is something that Donna is going to talk more about. Sometimes funders will only support one component of your program, so you have to piece together funding to make sure all aspects are covered. This is a key thing to consider when you're developing your admission criteria, which Dave is going to talk more about. And it's also something to consider when you're developing community partners and thinking critically about what services your program is able to provide. So with that, I'm going to turn it over to Kim, who's going to talk about program types.
Hi, thank you, Julia. My name is Kim Desprez, and I'm the RN Program Director for Circle the City in Phoenix, Arizona. I'm going to start my slides off by talking about key components of respite. Most importantly, you need to assess what the community need is. Many facilities, before they start, will do a needs assessment in the community, and they'll survey stakeholders. Stakeholders could be possibly hospital personnel, including case managers, maybe the C-suite, shelter staff, different consumers, and also health center staff. It's also important to look at the space and location when you're looking at opening up a respite. When you're choosing a facility, is it ADA accessible? How close is it to other services? And of course, transportation. Many of our clients, patients, use public transportation, so is it near a bus stop or a light rail? Those are important things to consider. The next slide I'll talk about when you're looking at the program model, what components would you like to provide, or what's important for your program? For case management, will you provide outreach, different education about resources in your community? Will you provide Social Security and Social Security disability resources and assistance? And also housing. Could they, when they're transferred or discharged, would they go to a transitional setting? Would they go to inpatient rehab? Do you have access to permanent supportive housing? For the clinical oversight, there should be a clinical interventions, and that could look a number of different ways. There should be at a minimum 24-hour bed rest. Will you provide IV antibiotics? What different medications will you provide? Will you let the patients hold on to them, or will you? Those all constitute different licenses. Will you provide behavioral health? I know trauma-informed care, motivational interviewing, and harm reduction are things that you probably will look into, along with substance abuse services. For the resources, when you're looking at opening up a respite center, one of the most important things is determine the scope. What are the needs in your community? It's really important, like I said in the first slide, to do a needs assessment. And what already exists? You look at community partners, and for example, look at other FQHCs in the community. Are there shelters that you can partner with, hospitals, social service agencies, behavioral health, and of course day centers? All of these will be really important. I'd like to point out that hospital collaboration will be probably one of the most important. I know we'll talk about that more in the upcoming slides. I'll talk now about the different types of respite. We've been pretty creative across the country with what a respite looks like. There are programs that have been in place with the landlord or managing companies, and like for motel rooms, a program in California was recently able to purchase an old motel that was going to be torn down. They've revamped it and now use the rooms for medical respite clients. A homeless shelter. Many programs start here because it's a natural partnership between the homeless shelter and the medical respite care. Sometimes the homeless shelter would be willing to set aside beds for medical respite clients. For transitional housing, there are programs like this across the country. There's one specifically in New York that's located in a transitional housing program, which is a fabulous collaboration. Some have used assisted living or nursing homes, and there might be a wing that isn't used or that can function in a nursing home for medical respite beds. I think that's probably the most creative I've seen. There's also substance abuse treatment facilities. There are one or two programs, I think, in New York that's co-located with a chemical dependence crisis center. And lastly, there are standalone facilities, and these are built from the ground up or have a building that's already in place and needs renovation. And I'll talk a little bit more about that in my last slide. So I'll talk now about my particular facility, Circle the City in Phoenix, Arizona. We're a standalone facility, and I wanted to add this picture. It's actually Super Bowl Sunday, and that's our TV room that many of the patients share. And here's a little bit more information. For our particular facility, we have 50 total beds. We have 40 for men, 8 for women, and 2 isolation rooms. For us, the isolation rooms have reverse airflow, so we are able to take patients with active TB, and we do partner with the Maricopa County Health Department. We also use those rooms for patients at end of life. We partner with the hospice, and so we do take homeless hospice patients. And then sometimes we are able to take patients with service animals, and we'll have them start in that room until the dog gets accustomed to the facility. We do have providers here 7 days a week, and then we have an MD on call at night for our staff. We have RNs 7 days a week, and LPNs also 7 days a week, and 1 LPN at night. We do also offer physical therapy. We do have a driver and offer transportation. We do encourage the patients to schedule their own transportation through the Access Transportation phone number. We have a psychiatrist on site along with substance abuse counseling. We do offer case management that helps with all the things that I mentioned before. It's basic as getting identification all the way up to helping them finding permanent supportive housing. Of course, all that's done in the average length of stay of about 32 days. We have peer navigation, and we really depend on our volunteers. So we have a lot of activities such as art, music, gardening, bingo, creative writing. We take those that are medically cleared on field trips, and so try to keep them active and out of trouble. So that's the end of my presentation. Thank you.
Thanks, Kim. Hi, everyone. I'm Dave Munson. I'm the medical director up here in Boston of our 2 respite programs, the Barbara McInnis House and the Stacey Kirkpatrick House. And thanks, everyone, for joining. I'm going to talk about clinical care and respite. And, I think I'll just preface my slides by saying that a lot of what I'm going to say is fairly general to provide really some guidelines and some to provoke some discussion and thought about the different models of clinical care that you can develop in your medical respite program. And certainly, if you have more specific questions, we can try to address those in the Q&A at the end. But I wanted to start, Julia alluded to kind of how we define medical respite, which I think is just important in terms of grounding the conversation. Short-term medical care and case management to folks who are generally homeless, recovering from an acute illness or injury, and those are folks that really can't be on the street or in the shelter. But the question always is like, well, what does that mean? And I'm sure all of you have, explained the numerous different types of clinical scenarios that can fit that criteria. I mean, there's really thousands I can think of. I wanted to share just 3 examples of patients that are with us here at the Barbara McInnis House currently, I think showing the different types of care that we can do. So one is a 34-year-old guy who came from the shelter. He has opioid use disorder and he has influenza A. We, as many of you, have been dealing with a flu outbreak in Boston that's starting to quiet down, but is still around. And we're trying to get flu patients out of the shelter. So we in our facility have some single rooms, as Kim alluded to as well, so we can get flu patients out of the shelter and into those rooms to get them treatment for influenza in a safe way. The second case, kind of speaking to the perioperative work that medical respite programs can do. So this is a 68-year-old man with pretty severe alcohol use disorder who has a large gastrointestinal stromal tumor that needs to be removed surgically, and really the surgeon would only schedule the procedure if they could ensure that he, A, had a place to detox beforehand, and also could ensure that he made it to the surgery safely and appropriately. So we can provide that service here and coordinate with the surgical colleagues across the city. And then the third, and I think probably the most common and the easiest place for you all as you're starting programs to think about is the post-hospital work. So a 55-year-old guy with asthma, depression, some opioid use as well, who was admitted to us after a stay at the local hospital for an asthma exacerbation. And we're able to sort of coordinate, take folks directly from the hospital, and coordinate medications and finish treatments, and then ensure a safe discharge back into the community. So our facility is quite large, the Barbara McInnis House. We are a standalone program. We have 104 beds on site here. We do have a 20-bed step-down program across town, but 104 beds in our main facility, and we're a fairly medically intensive medical model. That is will not be applicable for all of you, but I just wanted to mention what we do. So we have 104 beds. We have one nurse for every 13 patients during the day and one nurse to every 26 patients overnight. We have a nurse's aide role, which is kind of like a medical assistant to sort of do vital signs and some assistance with lab draws and things, not really around activities of daily living support. And our model here is sort of team-based, but we do, as I mentioned, have a pretty medically intensive model in which a provider sees a patient every day for medication changes and things like that. Our patients do not keep their own medications. We have medication storage, and the nurses administer the medications to patients. We have case management on site and social work support as well in the ratios as you see there. We also have about a full week's worth of psychiatry kind of split up amongst 3 or 4 different individual prescribers who can see patients as a consult basis. But I did want to mention that there are many other examples of programs across the country, and so you should just take these as models that you could potentially try to emulate. In the shelter-based sites, that might look like having a nurse on site, for 12 hours a day or so to be able to do wound care and other sort of basic needs. But then overnight, not having any real clinical staff, just relying on the shelter staff to call 911 if someone's in crisis, or responding to an emergency by doing basic life support. And then having a prescriber or a provider on site 12 hours per week to see patients as needed. And then as we mentioned too, there's many scattered sites. So whether that's motels or rooming houses or treatment programs. So one example of just a respite program that's diffused across the county, really just using rooms that are available. And this sort of leverages outpatient supports that patients might be able to connect with, whether that be visiting nurse supports, occupational therapy, or physical therapy to sort of, services that insurance might pay for to sort of work and coordinate with them. And then using your own staff, either nurses or community health workers, to really serve as care coordinators to ensure patients are connected to primary care outside of your respite program per se. And then a lot of those programs also will have sort of social work and case management on site as well, but not as much clinical support on site. So I think my takeaway point for this is just that there's a really broad range of program models that fit under this broad definition of medical respite, and you should think about what fits your needs. And I think that dovetails really well with when you consider what your admission criteria are, because your admission criteria and your staffing model are going to be tied intimately together. And I think things that you want to think about are, again, what your staffing model is going to be, what clinical staff do you have on site, And then what are the needs of your patients? So, in Boston, for example, over the past couple of years, we've had real, as many of you probably have as well, had to really sort of confront the opioid crisis and how it's manifesting in our patients and in our patients that need medical respite. So we've had to change our staffing and our admission criteria a bit to accommodate that. So you should consider what are the needs of your individual patients or clients, and then if you have referring partners, be that hospitals or community health center partners or shelter providers, what are their needs and what are their expectations as you go about developing your program so that you can make sure that you build a program that can admit and take care of those patients safely. And that's not a specific thing that I can tell you. That's something that you guys need to kind of think about at your own individual locations. But there are a few, I think, general issues that you could consider as you're developing this, and we'll kind of walk through them a bit here. The first is medication. So the patients who are on medications, how are you going to manage them? Are you going to have a model in which you have the licensing and to hold and administer medications for patients, as we do here at McInnis House? Or are you going to have patients kind of mind their own medications, either with a lockbox or some other sort of supportive way like that? How clinically complex and how clinically dynamic are the patients that you're going to take? Are you going to have the ability to support patients who need daily medication titration if needed, or other sort of dynamic clinical scenarios? This is, I think, something to keep in mind, especially if you're entering into a relationship with a hospital, because I think especially hospitals are going to continue to push us as medical respite providers to take patients earlier, and especially if a hospital sees you as a discharge, they're going to potentially have a few outstanding clinical issues that you're going to need to have the staff on site or the model on site to deal with. Just something to keep in mind. We often encounter situations with IV antibiotics where we're asked to continue a course for patients, and so you need to think about having the staff either on site or to be able to partner with staff who can safely administer IV antibiotics, manage a PICC line or a midline, and then have a contract with a pharmacy or some ability to get medications for patients. How independent are your patients going to be with activities of daily living? Are you going to have the ability to help someone take a shower, or are they going to, or help them get in and out of bed? Or is that something that patients are going to need to be fully independent for? That's sort of where we are. Our patients need to be fully independent with their activities of daily living, again, because we're much kind of heavier on the medical provider side than we are on sort of the supportive side that way. And then two issues that I think have come up maybe a little bit more recently are how are you going to manage substance use disorders on site? Are you going to provide on-site access to medication-assisted therapy with doing Suboxone inductions or Vivitrol injections? That, of course, requires, at least the Suboxone requires a special waiver and to having appropriate staff, and some folks may want to have additional substance use disorder counseling on site. And then we know about the high prevalence of mental illness amongst our patients, and just thinking about how you're going to support those diseases and the behaviors, I think, really that are associated with those behaviors for patients in your respite programs. So just some broad things to consider that I think, because those are all issues that you'll either be asked to deal with, or many of you are probably dealing with those already as you've been thinking about getting your programs off the ground. I wanted to close by just sort of talking a bit about it's really general medicine that we end up seeing in our respite program. These are the top diagnoses for our fiscal year 2015. It's a little dated now, and you can see the high volume that we have, about 2,600 total admissions in a fiscal year. We have a very short length of stay here, where we're only 14 days, about on average, sort of focused on fixing acute medical issues and then safely transitioning folks back to shelter, where we have an integrated healthcare for the homeless program in many of the shelters in Boston. So I'm going to end there, I think, and turn it over to Hannah, who will talk about case management and behavioral health.
Hi, everyone. This is Shauna Brocht. I'm with Healthcare for the Homeless in Baltimore. Similar to the other presenters, I just wanted to start with a bit of a caveat that what I'm going to talk about is the behavioral health and case management that we have here in Baltimore. everybody in your local area, you have your own set of resources of what's available in your community and also what the needs are. So it's not a one-size-fits-all, but I will just tell you a little bit about what we do here in Baltimore. And I would say we are pretty behavioral health heavy and less so medically heavy. So you can see kind of the variety of different programs that are here. So I want to start off by talking a little bit about the different kinds of clients we see in a respite program, and this is kind of how I think about their behavioral health needs. So there are the folks that come to respite who are familiar with the shelter system, have a primary care provider, are linked in somewhere already. But quite frequently we get the kind of folks that aren't engaged in any kind of health care or service provider. This is probably their first time reaching out for help. So some of these folks are newly homeless, have become homeless due to an illness where they lost their job and their home. Some clients are folks that are normally living on the street and avoid the shelter system, but finally realize that they need to reach out and get help due to their illness. And from talking to clients and doing psychosocial groups over time, one thing we've noticed is a lot of our clients really value their independence. That's a really strong value for them. And becoming ill, they need to be able to learn how to accept help from others. So that is another thing that behavioral health providers in general can help with. So in Baltimore, we have 25 respite beds. We are in a shelter, kind of different than what Dave was talking about in Boston. We do have quite a large number of behavioral health and case management providers for that size program. So we have what we call a therapist case manager, and I'll talk a little bit more about that. So we have 2 therapist case managers. We have a community health worker, and we have a psychiatric occupational therapist who comes for 3 hours per week. And I didn't put this on here, but we do, our clients do have access to psychiatry services through our clinic, which is down the street, but our psychiatry services are not on site. So what is a therapist case manager? So this is a role that we have here in Baltimore where we kind of combine the therapist and case manager role. So all of our clients get an initial behavioral health screening, so we're moving towards using the American Society for Addiction Medicine screening so that we can screen and appropriately place people in behavioral health and addiction services as they are interested. And we provide a lot of supportive counseling. Again, a lot of folks are newly ill, newly facing a chronic condition, sometimes newly homeless, so just having that someone to talk to, and then referring for ongoing services. On the case management side, we complete a coordinated access application for housing. We start income and benefit applications and assist with applying for IDs. We also have a psychosocial groups twice a week. This is our day room, and this is a picture of one of those groups, so pretty informal group. And we also our social workers, so these are licensed clinical social workers who have the therapist case manager role, and they also provide the interventions around behavioral problems on the dorm. So again, we combine the 2 roles of a therapist and a case manager because some clients are really reluctant to engage in behavioral health, but you can start to engage them through case management. This also fits our funding model. We have a very generous public behavioral health system in Maryland, so we are able to bill for the behavioral health component of our work, which helps fund that work. And as I mentioned, a great majority of our clients do have either a serious mental illness or a long-standing substance abuse problem. But even folks that don't have either of those, being homeless and ill is quite a crisis point in your life, and we find that clients benefit from supportive counseling. We also have a community health worker. This is our community health worker and one of our clients, and she does a lot of the work coordinating our transportation to appointments. And she also, one of our main goals is to connect people to primary care when they leave us. So we have community health workers in our clinic, so she's kind of the person handing folks off to them. And she also runs a residence meeting and engages clients improving life on the dorm, and also any kind of like client advocacy opportunities that we might have. She engages people for that as well. So we are very lucky to have a psychiatric occupational therapist in our clinic. This is our picture of our Psycho T. And so any of our CCP, any of our respite staff can refer clients for assessment and treatment. She helps with falls prevention, memory strategies, medication management is a good one. And basically helping clients organize for self-management. So clients who aren't used to filling their own prescriptions, maybe they've never had a prescription before, how do you keep track of your prescriptions and your appointments? As we all know, a lot of people experiencing homelessness have had a traumatic brain injury. So she is able to help folks with those kind of memory problems and organizational problems. And again, our public behavioral health funding stream allows us to bill for occupational therapy services. So that is one of the reasons why we're very fortunate. If you live somewhere that you cannot bill for occupational therapy, it might be a good idea to reach out to a local program to see if there are students available to help you provide some services in your respite. We found it's just been a huge benefit. So I just wanted to end with an example of a client and just some of the ways that we were able to help him on behavioral health-wise. So this is a client who was working under the table. And he became too ill to work, ended up in our respite program. He had never been engaged with any kind of medical or social services or the shelter system through coming through us. So through an assessment by our therapist case manager, he was referred for ongoing behavioral health services. And this was not a gentleman with really a long-standing behavioral health need, but just to help him adjust to having a disability and a chronic illness, which is a really big loss for people oftentimes to become disabled and not have that source of fulfillment in their life that they got from working. Our therapist case manager also assisted the client with applying for disability and finding market rate housing. Our community health worker helped him with transportation to his specialty appointments until he was able to learn to do that on his own. And our occupational therapist taught him how to manage his medications on his own, which he had never really been on medications before, set up a calendar and other organizational strategies so that he could be successful in remaining in primary care. So I will end with that client story and turn it over to Shakoya.
Good morning, everyone. My name is Shakoya Green. I am the Director of Pathway Recuperative Care, which is located in Los Angeles, California, and we are more of a social services-based model. So what I am going to talk about is starting a program, talk about when we first started our program in LA County, and then talk about the two different models which we currently have now, which are partnered with different counties and hospitals. So in considering starting a medical respite program, the first thing you need to look at is the need. So it's very important to know the landscape in your city or county or state for that matter, one of the things that we did is we looked at the number of individuals experiencing homelessness as well as the number of individuals with chronic medical conditions and chronic mental health conditions. We also looked at and did some research with the Hospital Association of Southern California and the hospitals, looking at how many individuals are going back and forth to the hospital and how often they are returning to the hospital. So knowing the need for your area is very, very important. Then you want to consider your location. So exactly what area are you going to open up your facility, and knowing the neighborhood councils in those areas, knowing the importance of building a relationship with your community, and looking at the not in my backyard individuals who don't want services in that area, and how do you strategize to get them to open up to being receptive to services being provided in that area, so that we're looked at more as neighbors in the community and not a burden to the community. Then we looked at funding. So when you're starting a program, one of the things that we did was we first looked at startup funding with grants, and we also did a pilot program. And speaking to my CEO who was here when it first started 10 years ago, she stated that they also looked at some of the smaller hospitals and they gifted them beds so that they could see the importance of how the program could be a benefit to the hospital, and why it was important to partner with National Health Foundation to start a recuperative care program, and the benefit of paying for the service so that individuals could get healthy and that we could assist them with finding, linking them to services and finding a home if possible. Then looking at the hospital partnerships, one of the key things that she stated to me was that when we first started, one of the hospital's biggest thing was they didn't want to pay for housing. They did not see that as being a responsibility of the hospitals. Now, as we see in the news, hospitals are more willing to look at paying for housing. One of the big things that they looked at was the cost avoidance. So how much is this going to cost us, and how much are we going to save? Like, what's the benefit to the hospitals? So what the research showed us that in LA County, individuals were staying in the hospital 4 days longer. Individuals experiencing homelessness were staying in the hospitals 4 days longer than an individual that had a home. So when we look at that, we look at the cost of an actual inpatient stay in the hospital versus the cost of what we were charging for recuperative care services. And then we also talked about the services that we were able to provide an individual versus them staying in the hospitals 4 days longer. And so where the cost then was about $3,100 versus our $250 per day for our services. So we were able to save them more money by sending the individuals and partnering with us. We were able to save the hospital money. One of the big things that we're looking at now, and a lot of our hospital partnerships are looking at, is the return rate. How often are individuals returning to our hospital, and how fast are they returning? So we are currently looking at data with one of our hospital partners to look at that. Where are individuals going? How fast are they returning? So you want to be able to present that data as well. So for us, we have two different models that we currently utilize. We have 40 beds currently in LA County, and we utilize a fee-for-service model. So you basically, the hospital sign a one-page letter of agreement, and they are able to pay per day as the individuals come into the hospital, and we bill them on the back end. We have a minimum length of stay of 7 days. And so we're not we're more of a social services-based model. So we have social service providers on site, and then we also have a medical coordinator who links the individuals to medical services and primary care services. In Ventura County, which we started in July of last year, we have a different model. Those beds are paid for up front by the hospital, and it's a 2-year program, so they're leasing a certain amount of beds. So again, in partnership with the Hospital Association, research was done, and it's with 5 different hospitals, and based off the number of individuals that they have that are coming into their hospitals, they purchase so many beds. So one particular, the largest hospital in Ventura County purchased 6 of those beds, and so those are their 6 beds throughout the length of for the next 2 years, and then we will redo the contract at that time, at the end of the 2 years. So it's 2 different models that you can easily look at. We do have a new program that's opening this fall, and so that one we're actually looking at IPAs and insurance providers as them leasing the beds as a possibility. So leasing the beds, you have fee-for-service, and then you have leasing the beds as an option for as one of the models, as 2 of the models, excuse me. So because we did a pilot program when we first started, we did have the opportunity, and our CEO, Kelly Bruno, wrote a summary report in 2012 and looked at our lessons learned from 2010 to 2012. And one of the big things that we did learn was having a customer-first culture. So not requiring the hospitals to fill out a 10-page referral sheet, better yet giving them a 1-page referral sheet, and then they can fill that in and send that 1-page referral sheet to us and send over the H&P as well as a list of medications, and then we decide whether they're eligible or not eligible for the program. The other thing that we learned was making sure that we respond as fast as possible. And at that point, it was about a 4 business hours return rate. Right now, we are approving referrals in 1 to 2 hours. So what I am learning and what they learned in 2010 was being able to give an answer quick, because the hospitals are looking for a discharge plan quick, so not having them wait. Also, the importance of continued outreach to the hospitals. One of the things that I've been here 3 years, and before I started, they had just hired a marketing manager. So when I started, our census was 12. Now our 12 individuals per month. Right now our census is averaging between 30 and 35 per month. But we have a marketing manager, and he is the one who goes out to the hospitals to market our program and to talk about our programs, to train on the referral process, to share our success stories, to send out a newsletter. He markets our program. So it's very important, depending on the size of your program and the size of the area. So we have, in LA County, we have letters of agreements with 60 different hospitals, with about 30 to 40 hospitals referring on the quarterly basis. But that marketing manager is important when trying to keep your program going. So you also want to establish service levels at intake. So right now we have a minimum length of stay of 7 days. So when the hospital sends over the referral, you need to make sure that you establish that length of stay. So minimally it's 10 days. If the hospital says to us, no, they need 6 weeks of IV antibiotics, then our expectation is that the hospital is going to pay for 6 weeks of service. But that's set up and established up front versus on the back end. And then, as we talked about, is the report on patient outcomes. So that is basically, we want to do the discharge summary. The hospitals and the social workers want to know what happened. What did the individuals do in your program? So we send out discharge summaries to the social workers within 48 hours of an individual discharging from our program. You want to make sure that your data is accurate, and then you also want to know service providers in your area so that you can partner with them, whether it be for medical services, mental health services, for housing services. You want to make sure that you know the partnerships in your area so that you can continue to provide great service and linkages to the individuals that come into your program. And be responsive. You want to make sure that you, as a director or the owner of the program, the social worker in the program, that you're responsive. If you receive a call from a hospital, always respond immediately. One of the feedbacks that my marketing manager always receives is that I receive regarding his performance is that he's always very responsive, regardless of what time the social worker calls or the supervisor's call. He's always very responsive. So you want to make sure that you are responsive. And now we will have Donna.
All right. Thank you very much, Sequoia. So you've heard a lot about different types of activities and interventions that take place in medical respite. I'm going to turn to program measures and outcomes. So you're doing all this great work. How do you demonstrate that? So here are a few questions to consider as you begin to think about program measures and outcomes. In the following slides, we'll go over each in more detail, but to begin, what are the reasonable expectations of your program? So some programs, as you've heard, are very large, some are much smaller. What can we expect from your program? Also, as you've seen in this presentation, there's many different types of programs. You may not have the capacity to deliver the same type of outcomes as larger programs. And as Julia mentioned as we began, some programs start small and build from there. So always consider that. You'll also need to understand what your stakeholders' expectations are, and you may need to help shape those. Stakeholders may have unrealistic expectations, so working with them early and often is important. And while you're thinking about your stakeholders, don't forget that they can be a resource as well. As for measuring and documenting outcomes, ideas are forthcoming. So reasonable expectations and outcomes. I think a key question to ask is, what have similar programs achieved? And how would you discover this? Well, the National Healthcare for the Homeless Council has a medical respite directory on their website. If you're thinking of developing a program, or if you already have a program, you could certainly go to their website and look through that medical respite directory. You may find a program in another state that's very similar to what you're planning on doing. Also, some states, for instance, those of us that are not Medicaid expansion states, may have different considerations or concerns than those Medicaid expansion states. So you could look specifically for programs in similar political environments that you may find yourself in and reach out to them. As far as technical assistance, many of the people who have medical respite programs got where they are through sharing information, actually getting information from other programs, and then developing their program. So many of us in the field, I guess, are happy to share information. The National Healthcare for the Homeless Council has a technical assistance program. You can reach out to them for technical assistance. But if you just make contact through the information provided in the medical respite directory, I'm sure many people would be happy to respond. Also, the literature is a great source of information. I've shared with you a reference here for a systematic review that was published in 2013. Even though this is a little dated, it can give you a good idea of what programs have accomplished and what's appearing in the literature. We've heard a lot about stakeholder engagement, and certainly it's really important as you begin to develop your program, but it's really important to think about as you're thinking through your measures and outcomes as well. By the time you're having a conversation about outcomes and program measures, you'll likely have a steering or an advisory committee. You should always ensure the consumer voice is represented because consumers may have specific things that they're hoping to get out of a medical respite program. After you have your advisory committee and you're engaging in these conversations around program outcomes and measures, it's important to assess the skill set of the folks on your advisory committee. Is there anyone missing? This is really one of the reasons I was invited to participate with our medical respite program. During the early development, funders were asking for data and a study was needed to even begin our program. So due to my academic affiliation and for other reasons, I had experience in working in an SQHC, and I'm a nurse, and had some case management experience. I was invited to the table, and now I'm one of the 3 core leaders of our medical respite and transitional care program. But I really want to put a plug in there for academic partners. We have a lot of resources at large academic institutions and even at smaller institutions and community colleges. Certainly we have the resource of students looking for projects to work on and to participate in. Your stakeholders will likely change over time for various reasons. It's really important to document all data, measure, and outcome decisions that you've made, and for transparency, this information should be available to all stakeholders. Some large organizational stakeholders may have a secured platform for sharing such information, like a Box account. Otherwise, if no private information is being shared, Google Docs may work well for your needs, and that's actually where we started with Google Docs. As for measures and instruments, you should be able to see that you do have access to some PDFs now under the Resource tab. And a little bit about our program. It's a small scattered sites model. We do not have a central building, but rather we put people up in a safe sober house or in a safe boarding home or motels during their recovery period. We have more resources in our community for men than women, so typically women end up in motels. Then we have a lot of resources that can come in and assist. When we began conceptualizing our program, we were quite ambitious, and we felt we could achieve the following outcomes. We really thought we could improve people's housing status. And I'm not saying that we could house every client we served, but improve their housing status from the baseline when they entered. We thought we could see a net increase in benefits. So I'm talking about SSI, SSDI, Medicaid, SNAP, different benefits for which participants or patients may be eligible, but were not yet connected. We thought we could show an improvement in physical and mental health. Increased general self-efficacy, so ours is a case management program, and just like Shauna demonstrated some of the things they do, we do some similar things, not with an occupational therapist, which is a really cool addition to a program, but showing people how to do for themselves as far as making their own appointments, scheduling their own transportation. And then also, certainly, we want to show decreased healthcare utilization. So for some of these items, there are measures available. For instance, health-related quality of life can be measured with various tools, and I give examples of the SF20 and the Duke Health Profile. Those are both open access or public domain documents. However, some items are dependent on other things. For example, improvement in housing status generally requires that a person has a birth certificate or a picture ID. And so there's these incremental processes that occur in order to get somebody somewhere. We wanted to capture those incremental items and report them as successes. So we developed a has needs form, and I believe that that is available as PDF for you, and it will be available after this webinar on the Healthcare for the Homeless website. But our has needs form has 4 domains, and it's the basics, benefits, finances, and supports for stability. And that's what we're trying to connect our folks to. At enrollment, we do an assessment. Do they have this item or do they need it? It's great because it helps us strategize our work, helps us prioritize our work, and then, like I said, document that incremental progress. We didn't invent this form. Actually, we've borrowed it from another program who gave us permission to use it and to tailor it to our own needs. So like I said, there's no need to go out inventing the wheel. Much of this is available for use. If you're deciding on a tool, for instance, like the SF20 or the Duke Health Profile, you need to really make sure that those are in the public domain or request permission to use them. Sometimes there's an associated fee with using a tool, or you might be breaking copyright law, or it could be a proprietary instrument. So just make sure you're following those rules. Of course, also you want to make sure that you're documenting satisfaction of patients and stakeholders. Patient satisfaction is typically documented on a survey. Stakeholders can be surveyed or small interviews. I want to go back for a second because I didn't talk much about healthcare utilization. Some of the measures we look at them all. But one thing we thought that we could decrease was emergency department visits. And initially when we started our program, we said that. And we found out through our pilot program that that wasn't the case. We had one patient in our mix in our pilot program that actually was responsible for 25% of all emergency department visits. And what we learned from that patient is some patients have special needs that our program may not be addressing. So anyways, I think that's where the literature and other people's experiences come in handy. You might not want to overpromise. If your hospital or one of your stakeholders is planning on seeing decreased emergency department visits, that is really a hard outcome to achieve. So I think I would really be looking at other programs to see what their successes are and assessing the literature for that. Now on to documenting outcomes. It's really important to document your outcomes to demonstrate your success. And there's a few different things to think about. There's different frameworks out there, and these frameworks can be useful when you even when you're deciding on what data to collect. Here you can see some potentially useful frameworks. We've used the triple aim to frame our work for a manuscript, our organizational strategic plans to report outcomes. So right now we're in the middle of implementing a strategic plan, and all of our program outcomes have to be reported through that process. Also, the community needs health assessment, or the community health needs assessment, excuse me, and community benefit implementation plan can be a great way for hospitals to showcase their commitment to your work and other various organizational missions. So anyways, those are some ways you might want to frame thinking about what data to collect, and also when you go to present it. Databases are needed to house your data. There's multiple options. The ones I'm most familiar with are Excel and REDCap. I think that many people are familiar with Excel, but REDCap, which stands for the Research Electronic Data Capture, this is a database that many academic institutions have access to. We now use REDCap for all of our data collection. It's pretty robust in its ability to run reports. Actually, our referral form is a survey that feeds directly into this database. And that way, all of our data, everything from the referral utilization data can be pulled through our academic medical system, EMR, into this REDCap database. So all of our data can be housed in the same place. So just another plug for the academic partner there, having access to these types of resources, such as this type of a robust database, may be in your interest. And now I want to pass over to Julia Dobbins, who's going to talk a little bit more about standards and resources. Take it away, Julia.
Thank you so much, Donna. This is Julia again, and I just want to take a minute to speak briefly about the Respite Care Providers Network, or RCPN, which supports the development of new and existing medical respite programs through education, through advocacy, networking, and research. Anyone can join the RCPN. Just go to our website. It's free and includes a quarterly respite newsletter and announcements about respite-related trainings and webinars. So in 2012, the RCPN Steering Committee created a task force to develop universal standards for medical respite care, really to ensure quality of care across the board. I mean, as you've heard and as we've talked, you know that medical respite programs look very different across communities, and so the purpose of the standards is really to ensure a level of quality across all medical respite programs. The standards were finalized and published 4 years after the task force initially met and were published in October of 2016. Those are available on our website and also available right here through the webinar. I want to go back just for a second. So this slide is really just a snapshot of the 7 standards, but the full document outlines specific criteria that lays out best practices in medical respite care. So I highly encourage you to look at the standards, and please feel free to reach out to me if you have any questions. In addition to the standards, the Council has several medical respite resources, including a toolkit on our website. We have a development workbook, and as Donna said, the Council provides direct technical assistance. So if you're wanting to set up a call to talk more about respite or be connected with another program, please reach out to me. Additionally, we have some upcoming resources that I want to let you know about. First, we are developing a guide and self-assessment as a companion to the standards for medical respite care. And the purpose of this companion is really to make it easier for folks to demonstrate that their program meets the standards. That will be published in June of this year. Additionally, our medical respite program directory, which we've highly referenced today in the webinar, is in the process of being moved online. So it will be a searchable directory, which we're really excited about, and it's going to be updated, and that will be live and on our website in late April. Also, our national conference is coming up in just a few short months in May. This year we're going to be in Minneapolis, Minnesota. And as part of the conference, there will be a one-day medical respite pre-conference institute, which is really just a fantastic opportunity for training and for networking. We're also really, really excited to announce our 2018 Medical Respite Training Symposium. It's the first ever medical respite focused national two-day training. That's going to be happening October 1st and 2nd in Phoenix, Arizona in Kim's neighborhood. More information will be available about this training in the coming months, but we are really, really excited about it. So let's move on now and move into our Q&A portion. If you have a question, please type it into the chat box below the slides, and we'll do our best to get to them. If for some reason we don't get to your specific question on the webinar, we'll try to follow up with a written response. So I'm going to start. We have several questions here, and I'm going to start with one about how folks are referred into respite and how programs determine when a client is ready to be discharged from respite. So Dave, I'm going to ask you to answer that one.
Okay, thanks, Julia, and thanks for the question. I think for the referral piece, it speaks a little bit to partnerships. So we take referrals. We have a centralized admissions office that takes referrals from all of the hospitals and emergency rooms in the city of Boston, as well as sort of internally from our Boston Healthcare for the Homeless program's outreach clinics, and then a smattering of other outpatient clinics, usually sort of surgical, sort of the savvy surgical coordinators in town will know to call us to sort of refer someone in for admission. And then that admissions group, which is led by nursing, kind of makes a decision based on what our admission criteria are and if there's a bed availability. So that's kind of how we work on admissions. And then the second piece was let me see if it was around understanding discharge. And I think that's the different programs that you've heard about today have different goals and missions, I would say. As our program is sort of focused on more on the medical piece, it's about understanding if somebody's medically safe to return, in our case, often to shelter, given the supports that exist there in our city. So it's really about a clinical assessment. Often there's other situations that come up, and those might be different in other programs if the goals may be linking to housing or other sort of programs.
Great, thank you. Any other thoughts on how you determine when somebody's ready for discharge by the other speakers? I think it's pretty similar across programs. Great. So the next question I'm going to move on to is thinking about trauma-informed environments. So this person asks, how do respite centers ensure trauma-informed environments with closed spaces and people struggling with substance use disorder and mental health? Any of our speakers want to speak to that?
This is Shauna. I'll take a stab at it. It is a little bit of a challenge in the shelter-based environment when the shelter staff are there overnight without your staff. That has been a challenge that we have faced. In terms of our own staff, though, that are there during the day, trauma-informed care is just part of our culture and part of what we train our staff in when they're hired. So I think making that part of your culture and part of your whatever behavioral management programming and procedures that you have is very important.
Great, thank you. And I'll just add a challenge to that. This isn't an answer, this is a challenge, but I know this is specifically a struggle for some programs that partner with homeless shelters. I think we all know that not a lot of shelters are really a healing environment, and Sometimes because of resources and what you have, it's the best option and it's a natural partnership, but that can be a challenge of what if your rules and regulations for your respite program don't align with the agency that you're partnering with. And that can be a struggle. So what if something that the shelter would exit somebody from shelter because of, but your respite program is not quite so intense about it. It's a real negotiation, I think, that has to happen when you're developing that partnership, and that can be a real challenge. So the next question I want to get to is talking about needs assessments and specifically how folks have conducted needs assessments with hospitals and with health plans.
So specifically, this is Shakoya. So specifically for us, we have a direct connection with the Hospital Association of Southern California. So when we first started, it was based on a crisis here in LA County where hospitals were being, it was stated that hospitals were dumping individuals down on Skid Row. And so when we first started, there was research done in conjunction with the Hospital Association of Southern California. The details of that, I do not know the specifics, but because of that partnership, because we're right next door, we were able to have that direct connection to do the research and then help to create this program and pilot it as a response to the hospital dumping, or the alleged hospital dumping.
Great. We also have some resources here at the Council on how to develop a needs assessment, and I believe those are available in the Medical Respite Toolkit. If for some reason they're not there, please feel free to email me. I know that we have some great resources in that area.
This is Donna, and I wanted to chime in on that one. In our area, we had to kind of prove that we had a problem. So anytime that we asked for medical respite support in our area, we were told there's no data to support that you really need one. So we did a needs assessment. We did actually a qualitative study of the experience of not having a medical respite program. So what was it like for providers and patients in the absence of one? We've published that study, but for those of you in an environment where people are telling you that a medical respite program is not needed, doing that type of a needs assessment might be valuable for you.
Julia, this is Kim. I think I would like to add too is for those states that do not have Medicaid expansion available, I think that the hospitals are even more willing to collaborate and have a contractor, some type of MOA signed in order to make sure that patients have a safe discharge. And sometimes it's, they'll pay for 2 weeks of stay, sometimes a week, just to make sure that there's a safe discharge.
Great, thank you, Kim. So the next question I have is around pros and cons of the different models of medical respite. So this person asked specifically about moving from a hotel or a shelter model into a standalone model. Unfortunately, we don't have an example budget for what a program costs because it just is so subjective and really depends on the community. But in terms of pros and cons from, for different models, I'll open this up to the speakers as well, but I think a lot of folks want to have the standalone model. I think that's sort of everybody's goal, but there are challenges with the standalone model in that you really have to do it all yourself, and that's expensive. I think that's the biggest challenge is finding a space, purchasing the space, renovating the space, running the space. I mean, that's a lot of work to do if it's not already up and running, and that's one of the real benefits of having a place that's already set up for folks to spend the night and basically live there. So, but one of the benefits of a standalone facility is you get to make your own rules, which is kind of nice. You get to set up the program the way that you would like to, and you don't necessarily have to compromise with another agency that you're sharing a space with. So those are my thoughts on that. Speakers, any other thoughts on sort of the pros and cons of different spaces where you house medical respite clients?
This is Shauna. I would say in a shelter model, you're pretty limited in terms of the acuity that you can accept, and you can't do things, well, I guess you could. It's more difficult to do IVs, for example. We don't have 24-hour nursing, so we can't do hospice. We don't have an isolation bed. So you're really limited in the type of referrals that you can take, even though there might be the need for it. So I think I agree with being able to do things the way you want to do. Also, again, addressing that trauma-informed care question, you can obviously you have more control over that if you have a standalone facility, and you can serve a wider range of patients that way.
And this is Shakoya. So we currently have two motel models presently, and we're moving into a standalone facility. But one of the things that we did in going into the standalone facility, we wanted to make sure that we did not lose certain uniqueness of having our motel model. And one of the things that we value is individuals being able to have some form of semi-privacy. So having in the motel, individuals are 2 to a room. So we didn't, in our new model, our new building, we're making sure that we still keep to some of that, so not putting more than 4 individuals in a room, which, as Julia said, it's really costly when you have a standalone model, but we wanted to make sure that we keep certain parts of it and looking at other grants to help fund that part of the program, being that we are a fee-for-service model.
Great, thank you. Shakoya, I think this question might be one for you to answer as well, but somebody had a question about NIMBYs, so not in my backyard, and was wondering, how do you demonstrate the value of the program to neighbors, and how do you address their concerns?
So in our current model, we don't have, or in our current setting, we don't have that as an issue because we're kind of in a secluded area. But as we go into our new building, we're right across the street from a park, right next door to some homes. So we do have a community engagement team that is really focusing on that particularly building our relationship with our neighbors. One of the things that we are looking at doing is having a community garden so that they're not feeling like we're just bringing individuals into the community. We want to be a part of the community. We're also going to host different activities at the community center across the street. So we're going to the neighborhoods and into the community and asking them what are their needs, and looking at our community engagement team to build services and resources around their needs while we're still bringing in our community, bringing in the recuperative care program. We have not opened yet, so I can't speak to how successful that is going to be or has been. We have not had any pushback at this point. We have been out knocking on doors, making them know that we're coming, as we do have our groundbreaking that is coming here in April and starting construction. So we are building our relationships, going to neighborhood councils meetings, and showing them that we are a partner and we're a neighbor, and that the individuals that we're bringing in are going to be neighbors as well.
Yeah, so it sounds like you're being very proactive instead of waiting to see.
Oh, absolutely.
Yeah. Mm-hmm. So somebody had a question about accessing data on hospital utilization, and where do you find that data, and how do you find cost savings for your region? Any thoughts on that?
Julia, this is Dave. In Boston, that's been notoriously difficult to get on a larger level, which I think in some ways it depends on the number of health systems and hospitals in your area and how easy or difficult that data might be to get. We've worked a little bit with one hospital here trying to identify some of our patients and understand their utilization patterns, but Boston's unique in the number of hospitals that are so close together, and they're often different health systems. So that's been a difficult thing for us to really figure out. We've had to go through the state to try to get some Medicaid claims data, but that's been difficult.
And so
Yeah, oh, go ahead.
I'll piggyback on what Dave said. So it's very hard for us because there's so many hospitals. However, we are doing a study right now looking at one of our hospital systems that we're currently utilizing. And they actually were tracking some of the information themselves and actually put out a report not too long ago, late last year, I believe, and talked about the return rate. And so now we're partnering and looking at that data as well and hope to present some data later this year, early next year.
So this is Donna, and I think that one of in our area, we actually own most of the hospitals, but the reason it's difficult to find the data is because homelessness isn't documented. Our providers typically do not screen and document for the social determinants of health, so when we have access to hospital data, we're not able to identify who was homeless, or certainly not able to with much accuracy. Anyways, I think that the whole idea of using the ICD-10 codes or different mechanisms that people have used, for instance, using the hospital address as the patient's address if the person's homeless to help identify homeless people in the EMR is very important.
Yeah, and the council has a great resource around that about asking and coding and how to encourage hospitals to code for homelessness to make it easier to identify what the numbers are to get more accurate numbers. So that's available on our website as well. So if that's something you're interested in, please check it out. I have a question about accreditation. So do any of the respites obtain accreditation from the Joint Commission, or do they tend to follow the homeless shelter guidelines?
This is Kim. We follow the homeless shelter guidelines. We do not have not sought out Joint Commission.
This is Dave. We're technically licensed as an outpatient clinic here in Boston, so we kind of fall under Department of Public Health, actually clinic regulations.
And this is Shakoya. So there is no license in California for recuperative care, so we follow the homeless services shelter process as well.
Yeah, that's something that we looked into, is whether or not respite programs could receive Joint Commission accreditation, and it's pretty challenging for programs that don't have very robust clinical services. I think Joint Commission is pretty intense in the clinical side. So I think the programs that do have Joint Commission accreditation, it's for their health centers, not directly for their medical respite services. That sort of lends nicely into the next question about Medicaid reimbursement and what programs are receiving Medicaid reimbursement and what that looks like for your program.
So yeah, this is Kim. I'm from Phoenix. I can answer that for us. When I first came here about 4 years ago, we did not have Medicaid expansion, so we relied heavily on our hospital partnerships. But since then, we have expanded Medicaid and now are able to bill the access health plans. And what we do is we're an FQHC, so we bill per provider visit our PPS rate. That's how. It doesn't cover everything, but we do a lot of fundraising also.
Yeah, so medical respite services are not a billable service as of right now. It is our hope and our belief that that will someday change, but how a lot of programs get around that is they have billable providers on staff who then bill. Yeah. So we have another question around certification and licensure, and this person is asking what sorts of certification and licenses are required to add medical personnel to your staff, so adding LPNs or RNs.
This is Shauna. I'm not aware that there's any licensing required based on the staff. I think someone else mentioned billing as an outpatient clinic. That's what we do. So we are an FQHC, so our respite services are considered part of our outreach. So our respite program is actually considered an outreach site. So yeah, each state is different in terms of licensing, but that's the way we do it here.
Yeah, this is Dave. We don't have any particular certifications or licensing with respect to our respite program. The providers and nurses that work for our Healthcare for the Homeless program are licensed by the state of Massachusetts, and then our health center has a credentialing process when we hire new staff. So it just falls under that.
Great. Somebody had a question about medical respite facilities that are co-located with assisted living facilities, and I just want to make a comment about that. It's not super common for respite programs to be co-located with nursing facilities or assisted living facilities, but it does exist. A few examples of those, there's one in Austin, Texas, that I believe is a partnership with a nursing facility, and I think it has about 6 beds. And then there's also several programs in Florida that are affiliated with or licensed as assisted living facilities, and that is related to licensing in Florida. But you can definitely see more about these specific facilities in our program directory, where we have it outlined what programs, how they're broken down by space. So what programs have motel respite services, what programs are standalones, that's all listed in our directory. All right, I think we're at the end of our questions. If for some reason we didn't get to your question, we will try and follow up with you in a written response. I want to thank our presenters so much for sharing their expertise with us today, and thank you to everyone for joining us. The webinar will be archived on our website at www.nhchc.org within the next few business days. At the close of the webinar, an online survey to evaluate this training will automatically open in your web browser. Please complete the survey. We really value your feedback. Again, thank you for your participation today. Take good care.